Welcome back to the Gillett Health podcast, where we give you tools to develop a balanced approach to health. I'm Dr. Kyle Gillett.
And I'm James O'Hara. Today we have a bit of a fun episode, and we're going to start off with a quote by Dr. Kyle Gillett. So what's that quote we're going to start with today?
It feels a little odd quoting myself, but my quote is that one of the main ways that men passively self-harm is that they just refuse to go to the doctor. If you look at statistics about attempts at self-harm or even suicide attempts, females do this far more often. But my theory is that males and females actually do this at the same rate. Men just don't self-report it. So a good example of this is, let's say it's a male and they're having some chest pain with exertion, and they go a couple months without mentioning anything.
Yeah, this is a really interesting idea. It's something that's unique. I don't think a lot of people are talking about it. So we're going to kind of unpack this and talk about exactly what we mean and what some of the data shows. So, for example, a 2019 study showed that about 60% of men aren't seeking out healthcare on a regular basis, only going when they have a serious illness. And then I think only 60% of men or so are actually getting their annual physicals, where you would be doing a lot of screening for these things that you want to know about before they cause harm. And we'll talk about the different levels of prevention as we get into the podcast today. But an interesting case that I saw a lot of times when I was working in the hospital was you have somebody who comes in, maybe they're in their 50s or 60s. They haven't seen a healthcare provider since their like high school sports physical or whenever the last time it was. And then they find out they have this health problem, that health problem, usually multiple things. And they would say, well, there was nothing wrong with me until I went to the hospital.
Yeah.
So is this a conspiracy or what's going on here?
Seems like a pretty high correlation of starting to get pathologies and diseases when you go to the doctor. So again, this is kind of what I call confirmation bias, where they say, oh, nothing was wrong with me. I went to the doctor and they diagnosed all these things that weren't really wrong. But it's like the iceberg. It was just coming up beneath the surface, and perhaps they were ignoring the part at the top. And maybe there is a lot of difficulty in life and time constraint, which I would certainly empathize with, and they just didn't have the time, or they wanted to have willful suspension of disbelief, which is where, or willful suspension of belief, basically where they're deciding to believe something or not believe something, just because it's more convenient at that time.
Yeah, that's a great point, and that is one of the top fears, one of the top reasons, actually the top two you mentioned. One is time constraints, which is not really a reason, it's more of a excuse and where that falls on your priority list. So if you don't have time for something, it just means it's not at the top of your priority list.
It's an investment in time. Would you rather have one less hour of healthy time right then at X age, or in 10 to 20 years, would you rather have 2 more years of extra healthy time?
Yeah. And the other part of that was fear. Men don't want to acknowledge that there may actually be a health problem there. So they avoid seeking out healthcare because they may actually get a diagnosis. Perhaps they suspect that there's something actually wrong, and they don't want to confirm that. So you can ignore that. And I know we always use a lot of analogies to a mechanic in cars with your health. You can ignore that check engine light, but over time, more and more lights are going to start coming on, and then you're going to have to take your car into the shop or take yourself into a healthcare facility of some time. Better to get those things checked out earlier rather than later.
Yeah, and some of this is personal preference. Just like there's personal preference, some people want to drive their car until the wheels fall off. Maybe, some people don't even do oil changes. Some people don't even go to the doctor for their annual physical in very, very basic screening labs. But if you happen to want to drive your car until 300,000 miles, and you want that car to perform well between 200,000 and 300,000 miles, you will certainly have to put in some preventive, tender, loving care into that car.
Yeah, absolutely. And we kind of talked about you mentioned the individualization of this. And this is something that I think is a little bit analogous with the concept of palliative care, which is even itself not really well understood. But it has to do with the decisions people are making at the end of their life with regard to healthcare how aggressive they want the interventions to be. If you're looking at, let's say, primary prevention, these are just health promoting behaviors. How can you prevent things from happening before they happen? Really what we're looking at with health maintenance and these regular screenings is secondary prevention. So if you go with undiagnosed high blood pressure for 30 or 40 years, you're going to have some collateral damage from that. You can't necessarily unwind that at age 60, whereas if you had an intervention at, let's say, 25 or 30, then that's going to really mitigate that. It's going to be a big harm reduction. You still may have a diagnosis of high blood pressure, and I think there is some stigma around carrying a diagnosis. People talking about, well, I don't want to have to rely on medication. I don't want to have to rely on this or that, and it comes a bit with that kind of masculine ideology of not wanting to be reliant, not wanting to show any weakness, which I think may be shifting a bit now, but historically there has been a big component of what's expected and what behaviors men are having regarding their healthcare.
That's definitely true, and some of that is what is fuel behind the fire of social determinants of health. And our colleague, Dr. Taylor Martin, who's board certified in preventive medicine and who has his master's in public health, at some point we'll have him on the podcast, and he will go into great detail with this concept of preventive medicine, primary care, and then as you approach the cliff, secondary care and tertiary care with safety nets, etc. Obviously, it's a much better use of public health resources and better for the individual to address things preventively. And some of those social determinants of health, for example, machismo, a lot of Latino males are, particularly underserved when it comes to getting preventive or even primary care. So looking at a lot of those things, and I suppose talking about it on podcast will hopefully make a difference. In addition, there's several government programs like Healthy People 2030 that are looking at these different interventions that are done proactively rather than reactively.
Yeah, and for the audience, you mentioned tertiary prevention. So this is after let's call it a disease has already taken hold. So somebody has a heart attack, and because the heart doesn't regenerate the muscle tissue, you have a reduction in your heart function. You have heart failure that develops. So then how do you try to reduce the harms of that further? How do you try to preserve this person's quality of life? That's the tertiary prevention, because you don't want to see a continued decline. You want to see, okay, how can we stabilize? How can we stop the damage? So if we go back to the very beginning and talk about the time constraints, major companies certainly place a priority on, let's say, their CEO's health. That's why you see a lot of executive physicals being done by these people, because they know that they don't want their CEO or CMO, whoever it may be, to have a major, unexpected health event. Investing that amount of time, and they do it in a very time-efficient manner. With an executive physical, you're getting a number of different screenings done, your physical exam done, blood work, a lot of times a colonoscopy, a CCTA, all the same day perhaps, getting all those things knocked out in a time-efficient manner. But it is a time investment, and you think, well, they're having their CEO spend 8 hours or 4 hours doing this. It just shows you how important it is to make that time investment in your health.
Yeah, and look at how much time a high-level professional athlete spends with essentially an interdisciplinary team. A physical therapist, an athletic trainer, a doctor, perhaps a chiropractor, a dietitian, like a sports dietitian especially. But that is a huge time investment, hours each week. And that's just in the health from the athletic standpoint for athletic performance optimization. If someone's profession is dependent on their cognitive health, a similar amount of time, or perhaps at least a decent amount of time, should be put into cognitive performance optimization.
Yeah, it really goes back to, the primary prevention. So you're going to have different lifestyle practices to prevent cognitive decline, to prevent your physical decline. And if you look at athletes now, their physical decline is much slower than it was 20 years ago. People are having careers that are decades long now instead of a decade long.
Yep.
And one of the things you mentioned, our colleague Taylor Martin, one of the things I like about the way he looks at things is, based on all the studies and the epidemiology figures that he's worked with, he's like, okay, what is the problem? What's the rate limiting step? What's the solution? So if we look at the concept of, either fear or perhaps a lack of awareness about how important these, regular health maintenance activities, physical exams, and so forth are, I think access to information is important. And podcasts have become a huge way to do that. So if you take a look at something like the, Mark Bell Power Project, it's a podcast that a lot of men listen to, and it's nothing that they would be embarrassed to be listening to.
Yep.
And there's a lot of good health information in there, especially about men's health issues and things that they may not have come across because men aren't going to sit down probably and watch a health program on television because it's not a masculine thing to do. But if you're listening to somebody who was a very accomplished power lifter talking about these different things, improving your quality of life, having various experts on, then it's something that's very it's not going to be labeled. You're not going to be embarrassed to listen to that. And I think it's a great way to kind of get that information out there in a little bit different way.
Yeah, Ben Pakulski would be another great example of that. Those are essentially public health initiatives. Now, some podcasts, their drive is to bring that information to the public with no charge. And, obviously you have to make money and you have to have a living. So it's difficult, for example, from my standpoint, difficult to go from a relatively traditional practice, practicing obstetrics, et cetera, and leave that job and then start my own clinic or our own clinic and do media for a large proportion of the time. It takes a long time to have monetization. So it's difficult for a lot of individuals that are credentialed and that are professional to do this. And sometimes it might be easier for an individual that has no alternative.
Yeah, and on the other side of that, we're talking about, I guess, the private sector, individual healthcare providers. Sometimes you do see some community or statewide initiatives, even at the federal level. Like you mentioned, Healthy People 2030. There are health fairs that have blood pressure screenings. A lot of times at sports events, for example, because they do want to, target men who are at a higher risk of things like high blood pressure, heart disease, and die, I believe, 5 or 6 years earlier than women on average.
That's another good example. There's kind of a standard of public health media information, and there's almost that's like the thesis, and then there's an antithesis of this pushback against the norm, I suppose. But there's not a lot of in between. We think that many people are in between. They're not necessarily just trusting and believing in the same healthcare system that we have, and they're also not trusting in alternative healthcare systems. For example, functional medicine clinics, as providers that have practice within conventional medicine and have an emphasis on evidence-based medicine as well, which we've talked about many times in the tier of evidence-based medicine, with expert recommendation being at the bottom of the pyramid. And also, as individuals who practice functional medicine, finding that happy medium in between for each patient, that's where a lot of the practice of the medicine comes in. And unfortunately, a lot of clinicians have kind of gone away from that and they're practicing more algorithmic medicine. That's another reason why many men and women as well are turned off of the healthcare system. They feel like if they go to their family doctor or they go to their GP, they already know exactly what's going to happen. So why even go?
Yeah, I think that's a great point, because for better or for worse, medical practice has kind of been labeled as, oh, here's a problem, here's a pill for that. And often that's not really what happens, but there certainly is a big degree of, guidelines that are involved. And you could say that, well, your average primary person, probably 60% of their job is going to be, type 2 diabetes, here's the pill, here's the screenings for that. High blood pressure, here's a pill, here's screenings for that. You have high cholesterol, here's the pill, here's the screenings for that. And certainly I don't think that they are discouraging people from doing things with their lifestyle. They're not saying, how could you get more, refined carbohydrates in your diet, or how could you get exposed to more pollution? Typically we're looking at the opposite. They are providing advice. Typically it's very simple, like, get more active, or, try changing your diet, this or that. But you really can't do a individualized plan in that short time frame. So the emphasis of the visit, the take-home point is, I have this, so I'm taking medication now. Mm-hmm. And there's different levels of intervention that people are willing to accept. And it's kind of a societal thing and also individual. So if you look at what people think is reasonable, and this expands into other things like experiments with animals, even what animals some people are willing to eat, and into what healthcare choices someone wants. It's going to be on a spectrum. Some people want nothing unnatural. Some people are willing to sit down and listen to the risks and benefits, which is a discussion that we always have with everyone, a realistic way of, okay, here's what happens if you do nothing. Here's what happens if you use a pharmaceutical. Here's maybe a supplement that could be complementary. But we're very realistic about somebody taking red yeast rice is not going to replace their PCSK9 inhibitor, for example.
Mm-hmm. Yeah, it's kind of like karma. Even doing nothing, you can still accrue some degree of karma, whether it's positive or negative. So there's always a consequence of action or inaction.
Yeah, and I think another thing is a lot of people will, or since we're talking kind of about men, but this could happen with women too. I actually have a story about this, but they will kind of say, well, this is happening just because I'm getting older. Mm-hmm. And I had a preceptor back when I was in clinical that a lot of things do happen with age. So people will tend to get these bruises on their forearms, skin thins, subcutaneous layer thins, too many birthdays. And that is probably an accurate statement for certain problems. But for others, there are very clear pathologies that are not age-related. They do happen more in older age, but it's not just because you're getting older.
Yep.
So in this particular story, there was a woman who was I think she ran 5Ks or 10Ks, and she came in and was talking about how her run times had gone up so much. She was much slower now, just getting older. She's kind of laughing it off. And he told me this story. He listened to, did the physical exam, was listening to her heart, a very pronounced murmur. And she actually had aortic stenosis that was impairing her physical performance. And she thought this was just related to age, but aortic stenosis, to kind of explain a bit of a background there, it's a narrowing of one of the valves of your heart. And when that opening is narrowed, your left ventricle has to work harder to pump the blood into systemic circulation, and that puts extra strain on that. You're going to end up with cardiomyopathy, enlarged left ventricle, and then can lead to heart failure if it's not addressed. Typically, it's a valve replacement that is much less invasive than it used to be. A lot of times they're doing TAVRs now where they can go through like a wrist and the groin as opposed to having to have open heart surgery. Bit of a rabbit hole there. But the emphasis, the take-home point from the story is if you're slowing down and you're getting older, you may not just be getting older. There may be a health problem there, and some people may not want to know. So I think we really need a societal shift in what people, what the expectation is. The expectation should not be you're a man or you're a woman and this is just what happens when you get older. But hey, if something has changed, there's usually a reason for that. Sometimes it may be aging, your systems do decline to some degree, but sometimes there may be a pathology there.
Yeah, that's very true, and it happens very often. It's not necessarily something to get too hung up about, but if you see a doctor and they say, oh, that's just due to aging, and this has even happened to my family members as well, don't worry about it, you're just getting older. There's aches and pains. And occasionally you'll find something that, for example, you need a joint replacement, which happened very recently to a close family member. So if you still have symptoms and it just doesn't seem right, then keep digging. The doctor or a different doctor, a second opinion or a third opinion, can always keep digging. And the main downside of that is that it takes more time and potentially more resources. But if you feel like something's wrong, it's like an airport. If you see something, say something.
Yeah, I think that's a good take-home point is you see something, say something. And, it can be a big time investment to try to establish that rapport with a care provider. You may, just not click well with the first person that you see, whether that's physician, physician assistant, nurse practitioner. So reading bios can be helpful sometimes. If you go on the website of whatever health system you're seeking care in, you may see someone who you think, oh, well, their beliefs align with mine. And then we're a big proponent of shared decision making. So we think that the patient should be a active participant in developing their care plan. So, what's really important to that person? We see a lot of times when people have either their children or grandchildren that they take a renewed interest in their health because they want to make sure that they're still able to do the things they're doing now, 10 years from now, 20 years from now, and so forth.
I think that's a good place to end this podcast on. So hopefully this has been helpful. Feel free to share this or comment your experiences. We would love to see them, and also comment on those experiences as well. And once again, we appreciate all of your time, and we hope that you have good health and happiness.